Hey, Montita.
Hello, hi, Dorian.
How are you?
Good. Nice to
Good.
see you.
Good to see you too. You want to go first? You're good with going first?
Yeah, I think but up to you.
Oh no, whatever you want to do is fine with me.
Yeah. But yeah, I can go first. I just like thinking that, but hope I will be like in time within 30 minutes. And
Yeah,
please
okay.
interrupt me if I go over time.
No worries. I can shorten mine if needed. That's okay.
Yeah.
Dr. Shelgikar.
Hello. Thank you both.
Yeah, sure. Where are you today? This is the
This is the
Union?
the Michigan Union.
Very nice. Hey, how's your daughter like in Michigan?
She really likes it. Yeah, she really likes it. Thanks for asking. Yeah.
Awesome.
I think especially the second year, you get more acclimated to things and taking classes that you enjoy. Yeah. So thanks.
Which dorm was she in?
South Quad?
Oh, that's a great draw.
Yeah. Yeah. And she's living off campus in a house, so she
Is
really
she?
likes it. Yeah.
Nice.
You already have
Does
a
she
college
join?
grad, right?
Don't remind me.
Oh, it's amazing.
Yeah, she's in Chicago.
Oh,
Working at
very cool.
Northwestern. Yeah,
Nice. Working or getting another degree?
working.
Okay, cool. Excellent. And then how did Dexter fare in the state playoffs?
We're still going.
You are.
Yep.
So going to the finals?
It is the regionals this weekend. So there are 8 teams left.
Oh, wow. Congrats.
Yep. And then we win this week. Next week would be the semifinals. And then if we win that, it'd be Ford Field,
Oh my gosh, that's
the
amazing.
championship.
Amazing.
Yeah.
Well, fingers
It's
crossed.
been fun. Thank you. It's been fun.
Should I start
Yeah, I
or
was just
waiting
going to say,
for?
whenever the two of you want to get, yeah, if you're going first, go ahead, whenever you
Yeah,
want.
yeah, going first. So let me going with the my difficult case presentations, but we'll like maybe have the input from the fellow and audience as well for some questions. So So the patients came in with their abnormal sleep study results that present to the clinic. So it's a 4 years old boy, doesn't have like much like past medical history, and come to our clinic regarding of the concerns of his sleep study results. He even visit central doctor like 5 days prior to the visit to discuss after removal of the tonsils, and he is accompanied by his parents. Sleep study from the outside facility show an apnea-hypopnea index of 118 per hour. And then from the study that I can see, it's like a OAI was 1.1 per hours, mixed apnea index 1 per hours, and central apnea index 50.4 per hour, and then hypopnea index 65.6 per hours. And the lowest oxygen saturation was 83%. Duration of oxygen less than 89% was 6.3 minutes or 1.7% of total sleep time. PLM was 0 per hours, and total CO2 doesn't meet the criteria for hypoventilations. So, yeah, what are your thoughts on the findings from the sleep studies?
Looks quite severe.
Which one? Which one is
I mean,
severe?
what was it? AHI was over 100. I don't think I've ever seen that in a child, but I'm also not a pediatric doctor. Yeah, 118, that's pretty significant.
Yeah, agree with you. Maybe like for me, I saw the sleep study, just thinking of someone that have to have craniofacial anomalies or someone that have like a genetic syndrome like Prader-Willi or like a trisomy 21. So when I see this one, I'm just like, oh, this patient when come to my like clinic look like no dysmorphic. So it's just kind of like wonder like what is this? So thank you for your thought. Anyone for any thought?
Looks
Yeah, it
like
makes me-
Rebecca put something in the
Oh.
chat too.
Yeah, Dr. Madeline said that do they subdivide hypopnea to central or obstructive or not? Yeah. Yeah, so this is another one too. Yeah, and Rebecca said like we're very curious about hypopnea. Yeah. And then Brad said like any like cardiopulmonary disease. Yeah. Yeah, that's all the good thoughts. So let me continue. So I pull the study from the outside that even doesn't have interpretation from the doctor, but have the information that we have. It seemed to be the AHI like 118.1 per hour, just say here in obstructive apnea hypopnea index. But when we look in the detail of the respiratory events, it seemed to be like the hypopnea doesn't have any differentiation between central obstructions. But definitely the central apnea index was really high, so 50.4 per hours. So so when I see the patient, I think it's kind of like really doesn't get into the patient, like it doesn't seem to be like from the patient that I see. I never see anyone that in normal child that really high like this. How is this kind of like true, or we have to like find out more, or is this a complex sleep apnea with both central and obstructive sleep apnea? So history of present illness when talk to mom and dad. So patient's mother reported that he has been experiencing episode of apnea. So breathing pause was lasting up to 10 seconds, followed by 2 breaths. And this pattern has been observed intermittently over the past 4 to 5 months. They didn't talk as much about the snoring, but more of the apneic episode. His father was also work in medical field, so he feel like the breathing look labor and obstructed, and also has a mouth breathing. Another thing that's kind of quite different from this child that I see from other kids is that dad say that he also has a mouth breathing during physical exertion and sometimes seem to be struggle for breath during that leading him to slow down or stop activities such as running. Because I see some severe sleep apnea, but sometimes doesn't have that much about the have to be slowed down during running or things, unless they have like asthma, like exercise-induced asthma. And then he also exhibits some movements during sleep, and he doesn't seem to be sleepy compared to his siblings. On the sleep schedule, he seems to be has a good bedtime routine, having snack, watching a short show, and then go to bed around 8 p.m., sleep for 10 to 11 hours per night. And for the past medical history, he has a history of RSV infection at age 3, which required nebulizer treatment. And following this, he was noted to become easily breathless with exertion and was prescribed albuterol inhaler for use during physical activities. And his primary care physician has not yet confirmed a diagnosis of exercise-induced asthma, so he has no other known health issue. So, and his birth history was no complication. He developmental history because of the thing of the central sleep apnea. So I asked all the developmental history. He also has like a little bit zoned out, but no sign of any seizures or other neurological symptoms. and there have been no observation of cyanosis or pallor during sleep. And then no any exhibit any nystagmus or other abnormal eye movements. And family history, his maternal grandmother has asthma, and then and tonsil and adenoid removed at young age, and his maternal grandfather has snoring. Physical examination, he looked really alert, awake, and he has a tonsillar hypertrophy, a little bit crowded oropharynx, and neuro exam was normal. I didn't look at his optic disc, but other than that, I do the full neuro exam that looks like normal tone, normal reflex. So what should be the next step? So I didn't do the like automatic, maybe like I need like the hand on to see like A, adenotonsillectomy, then follow up, B, urgent horizontogram, C, MRI brain with cervical spine, and D, iron study and ferritin. Oh, okay.
Question, Dr. Veerabegum, what was his baseline oxygen saturation during the vitals? I missed that.
Oh, the baseline oxygen saturations during the sleep study.
No, when they came to see you, in clinic, the vital
Oh, the
signs.
baseline oxygen. We didn't do the offset for everyone, but for him, he looked no cyanosis at all. Like look like a normal, like 98%, something like that. So who go with A? So I think like we have Brad like B and C. Okay. Yeah, you know, like it's I think like I even think that he already scheduled tonsillectomy on July, but like I say, like I never see anyone that very severe. Is the polysomnogram is an accurate one, because it doesn't reflect the patient that I see. So, but I even say that because he may have some obstructive sleep apnea from this sleep study, he could go with the ENT. But I'm glad that we got urgent polysomnogram like just one day after the clinic visit. So this is very like impossible, but we got it. So with the polysomnogram from our is really true central sleep apnea. We can see now like with the apnea is AHI was 51.8 per hour, and central apnea index was 51.2 per hour. So the hypopnea is only 0.5 per hours, and the oxygen, the mean was 96% and minimum was 85%. So from the interpretation is the C. Now we got from like this is a complex sleep apnea to severe central sleep apnea. And his central sleep apnea was more in the consolidated non-REM sleep. That is more like toward the respiratory center as well, but no any shin-stroke breathing. And carbon dioxide was normal, no any hypoventilation. So I like to show the hypnogram that he has really good architectures with like stage slow wave sleep and also the REM sleep. I think like he moved between the lateral and sometimes on the prone, but you can see very frequent central apnea and frequent oxygen desaturation with the severe central sleep apnea. So at least now we kind of like skip the adenotonsillectomy. At least I saved him one surgery because we got the sleep study before he almost scheduled to have the tonsils and adenoid out. So what should be the subsequent course of action?
MRI.
A, refer to cardiology,
above.
B, MRI with cervical spine, brain with cervical spine, and C, pediatric oxygen titration study, and D, all of the above. I think like Julian say MRI. It'd be like
The only thing I would say that caught my attention, I don't know if this was like his vital signs that stuck out to me when you guys saw him in the office. His heart rate was 100 and above 100, and his blood pressure was 87 over 60 something.
mhm,
That I'm not a pediatrician, so I don't know what the normal ranges are. But if I saw that in an adult, I'd be concerned that there's something else going on. It's no reason why this kid's getting short of breath with any sort of activities. Dad saying he can't do activities as a 4-year-old. That's
mhm.
that raises some questions. That's the only reason why I probably do all of the above. Maybe like not just an MRI, but also like a pediatric cardiologist evaluation as well.
Mhm. Yeah, I think that's a good thought for me because I think another one that I have to say too because he like when he running he really running out of breath and then really like a kind of like a have to slow to running and thing. So basically I did all of the above. So the one that got in quickly is the cardiology, like 1 week later. But if you look into his family history, he has kind of like have some kind of congenital heart disease and thing in the family as well. But his EEG and echo is normal. And I think from the cardiology perspective, it's good too, because sometimes severe central sleep apnea can also have the effect on the heart. So to have the echocardiogram to see that no any effect on the heart from the severe central sleep apnea, also the another good implication other than find out the cause, but also find out the effect, vice versa, between central sleep apnea and our cardiovascular health. So, and then next one I got is the pediatric oxygen titration studies, which seem to be oxygen help, but some central apnea still persists, even highest tested pressure of 1.25, and we recommended 1.25 liters per minute. And then the next one is the MRI. So you can see the MRI brain with the cervical spine. Yeah. But I think this one is very, very crowded. You can see the caudal, like descent of the cerebral tonsils, and you can see around like 2 centimeter below the foramen magnum. And even the medulla seem to be like sliding down a little bit too through the foramen magnums. And so so this is a quite like really crowded one. And from the full MRI results, other than the Kyrie Taiwan malformation that we see, it's also we have to sometimes when we debate about MRI, is it MRI brain or MRI brain with cervical spine? Sometimes we like to look at the syrinx because the Kyrie 1 malformation can cause the syrinx too. So that's why like we recommend like MRI brain and cervical spine with the central sleep apnea. So no identified syrinx in the cervical and upper thoracic spine. Also has a prominent bilateral adenoid and tonsils, which could be normal in this age, and also like enlarged bilateral level 2 of lymph nodes, likely reactive. So clinical cause, he was referred to neurosurgery with Dr. Marupati and underwent the suboccipital craniectomy of Kyrie decompression on August 29, 2025. So I'm good that he come in with the central sleep apnea because I asked him does he have any headache, no any sign of increased intracranial pressure. So I'm good that he's come in from this and we can diagnose it. So after surgery, his mother reported that the sleep quality has improved significantly since the surgery. Seems to be doesn't see the apneic episode anymore from his mother's standpoint, and his saturation was maintained even 98 to 100% throughout the night without supplemental oxygen. The pause is only maybe 1 to 2 seconds, no snoring, and he like seemed to be refreshed. And he will have the sleep study coming up in this December, so we can see how he look after his surgery. So for another 5 to 10 minutes, I want to go over a little bit about the central sleep apnea in children, but just for the management for the central sleep apnea. So the first significant one of the central sleep apnea in children is the central sleep apnea more than 5 per hours. If it is like yes, we have like evidence of obstructive sleep apnea in the PSG or not. It's like from our first one, if we like believe this is true, accurate. So yes, treat the OSA. And then if we treat the OSA, if the patient have to be on like an IV, if yes, if we have like CSA with an IV, we allow the acclimation of the time for the TEXA management. And then if we do other things like adenotonsillectomy and have a resolution of the OSA, we come back here like yes. And now we see that they have hypoventilation or not. If we have central apnea with the hypoventilation, the other one that we have to think about in children's and to like and sometimes if it's mild, we can find in like maybe like toddler and older children as well. For the FOX2B mutation regarding of central congenital central hypoventilation syndrome. So if we diagnose with congenital central hypoventilation syndrome, normally we do the NIV, or sometimes if we found it really young, have to be trach. And then if not this, we doesn't find the FOX2B, we have to see any obesity. Another one before they call like late congenital central hypoventilation syndrome. But if it's the obesity, it could be from obesity hypoventilation, or another one is the ROHATS that also has the hypothalamic dysfunction and the rapid onset of obesity. I think I saw one with Dr. Hassan when I was trained fellow here for the ROHATS. I saw one, but other than that, I never see ones. But I saw one in back at UFC is the obesity hypoventilation when I have 2 years old with 60 kilogram of weight. It's with a 2 years old, but at first I think he's a ROHATS too, but turned out to be just obesity hypoventilation. And then we do, if it's yes, we do like weight management, plus or minus NIPPV. And then if there is no hypoventilation, so we have to find the cause of etiology of the central sleep apnea. So we recommend like a cardiopulmonary workup and also like brain plus C-SPY MRI, and also like a thyroid function test as well. And if we doesn't find anything, it's just the idiopathic. And sometimes I have to see like which that we see common in children, but the CSA was not that really high, like to 100. So, but maybe maybe around like maybe 2 to 10 per hour. Sometimes we can see it during like with the obstructive sleep apnea, and children have like arousals after the obstructive events, and then have central apneas frequency. And normally they have a research that central apnea decrease with the after adenotonsillectomy. And then if we have idiopathic CSA, or we have CSA from other causes, the management could be like watchful wetting or supplemental oxygen, NIV or tracheostomy. So this is just a wrap up for the management for central sleep apnea. So I think I saw on the chat, is Chiari 1 usually associated with this degree of CSA? Yeah, I think so from Brad. Yeah, I think maybe not 100, but maybe 50. I have another one like young, older, like around like 10 years old that diagnosed before him but he has a headache on the back of the head, and maybe like some allergy symptoms that could be associated with, and then he has to repeat the sleep study after decompression and central sleep apnea was gone. So I think it could be associated with this degree of central sleep apnea for sure. And then from Lisa.
Can I ask a little more about that, Cheetah? Is it like is there any estimate of how many children with Chiari type 1 have central sleep apnea?
I I don't think that I have this information, but I think when I have the central sleep apnea, that
Yeah,
really
it'll often be
yeah
TR.
yeah, and then I think since I'm here for a year, I diagnosed two already that have Kyrie one malformation. I think when I asked Lisa, they a couple from central sleep apnea too.
Yeah. So if you're saying if you have CSA in a young child, you better think of Chiari-1 and it'll be a common finding. But if you just went out and did a study of all, because some people with Chiari-1 are asymptomatic, right? I mean,
Yeah, definitely.
and so
And I have to
I-
Oh, I have to say, like, Kyrie one is not the most common one. The most common one that I see mostly is the restless sleep, and then have like central apnea, and then with the iron and ferritin is better. I think this is a rare one, but when we found it, it's just kind of like if it's really severe, it's more likely to be from the brain and Kyrie one. Okay. So Lisa said, I have seen it on rare occasions with AHI in 1890. Okay. And if the patient has a persistent TEXA on an IV, would you recommend oxygen or ASV/BiPAP ST? So for me, I recommend like acclimation in children, especially if he already doesn't have any cause of central apnea anymore. But if the acclimation doesn't work, I think the next step will be the BiPAP ST. Okay, all right. So so everyone know any further questions then? Okay, so we'll give next to Dr. Annette then.
It's a
Mantita,
great case, though. Thanks for bringing that.
I'm gonna share my share. All right, seeing a slide?
Yes.
You need to give me a thumbs up. It's good. Okay, thank you. So afternoon, everybody. Mantita, thanks for that really interesting case. I'm going to ask everybody to take off their physician's sterile lab coats and put on your psychologist's cozy cardigans for this next case that we're going to talk about. I chose a case, not so much for the case itself, but really, I think it's emblematic of a difficult issue we confront in our BSM clinic in particular, and I'm sure you've confronted in your practice. That's working with somebody who comes in with a goal, either explicit or implicit, of trying to reduce or stop their sleeping medications. So I'm going to present a case of somebody I saw in the last year, invite comments and critiques on my approach to the particular case. And then at the end of the case, I have some just clinical discussion issues I'd like to present to the group, and I'd be grateful to get feedback about them. And then if there's time, we can also discuss some of the research trials that have gone on in this area in participants who are absolutely interested and committed to reducing or stopping entirely their sleeping medication. So I've called this case Snatching Defeat from the Jaws of Victory. Little play on the usual turn of phrase, and you'll see why in a second. Okay, so this is somebody I saw last year for 7 visits between May and October of 2024. I'm going to present the full initial new patient visit and then most of the return visits, because I think it's really instructive to see the degree of ambivalence a lot of patients have. And I think this is really a canonical example, at least in my practice. People don't typically come in with a firm commitment, absolute, I'm getting off this medication, but most people are somewhere in the middle. They're ambivalent. So I think going through most of the return visits will be instructive and seeing the degree of ambivalence that patients typically have, and in some ways how this patient was able to work through it. So this was a relatively healthy 51-year-old man who was actually self-referred, and he came in with chief complaints of difficulty sleeping without Ambien. That was his primary complaint. He'd always been a light sleeper, but generally he didn't have trouble sleeping at home before March of 2024. His general home routine was that he'd get into bed with his wife, watch TV, fall asleep typically before her. He'd wake up several times during the night, but he was able to return to sleep easily. He may have been a little bit tired in the afternoon, but never had any concerns, never sought any treatment for sleeping difficulties. He did have challenges when he traveled, both domestically and internationally in particular. So when he traveled domestically, he'd have a harder time typically falling asleep, and that was really his main sleep issue when he had it. And he had then even more difficulty when he traveled internationally, which he did regularly, at least twice a year. And there he'd had ongoing difficulties while he was overseas. So in those situations, he would use Ambien. He'd use typically Ambien 5 milligrams on these occasions. He'd get through those trips. When he returned stateside, returned home, he'd discontinue the Ambien, go back to his normal, relatively reasonable sleep routine. In early March of 24, he went to Europe, and he noticed he continued to have trouble sleeping, and in particular, falling asleep for a few weeks after returning. Initially, he tried to wait it out because historically he'd gone back to sleeping normally when he returned after he dealt with any jet lag, but his difficulties persisted. So he tried over-the-counter medication, in particular, he tried Sominex, had no benefit from it. And so then he tried brief prescription trials of both trazodone and promethazine, both of which made him kind of groggy. They weren't particularly helpful. So he tried some CBN gummies, didn't find benefit from those, and he was getting increasingly anxious about not being able to sleep. And he felt, quote, unnerved in his description. So as a result of these experiences and still having trouble getting back to his normal sleep, he resumed nightly use of Ambien 5 milligrams, which he'd done about 2 weeks before I saw him in May. And he was sleeping generally well on it, but he was generally concerned about what he said, what he quoted as the consequences of long-term use of the medication. When I asked him about daytime impacts when he wasn't able to sleep well, he said he was, quote, literally useless. If he got 0 hours of sleep, he was just literally useless, but he couldn't nap. If he got 2 to 3 hours, he was able to work, but he felt, quote, exhaustion. He wasn't sharp. He had a lot of anxiety, felt more irritable. And over the past 6 or 7 weeks, he had what he called anxiety attacks, which he'd never had before during the daytime, and he attributed these specifically to his sleep difficulties. These were otherwise not something he experienced. He had a lot of sleep-focused worry, particularly when he didn't take the medication. Am I going to be able to fall asleep? I'm going to feel terrible tomorrow if I don't sleep. He had mental arousal. He was physically tense in bed on days he didn't take the medication. Sleep hygiene was not terribly interesting. He did nap a little bit on the weekends, nothing related to caffeine. He did have a lot of evening events. He was involved in politics, so he was out several evening events during the week. And there he'd have maybe 1 or 2 drinks 3 or 4 nights a week. He'd had that prior trial of the CBN gummy, otherwise no recreational drugs, and he was an avid exerciser with a trainer at a good sleep environment. When I asked him about his strategies he used when he's not able to sleep, he would typically either repeat lists of things he'd memorized, like lists of presidents, or he'd read his Kindle with the blue light filter on. Occasionally he'd get up and go to another room, but then he would invariably say, oh my God, now I only have X number of hours left to sleep. So here was his self-reported sleep schedule. Again, this is now on Ambien 5 milligrams nightly. On the weekdays, you can see he got into bed about 9 o'clock, where he'd watch TV with his wife, read, be on the phone. A little bit later on the weekends. Lights out 10:30 to 10:45 on the weekdays. Weekend, more like 11 to 11:30. Fell asleep quickly. Few minutes to fall asleep. He'd wake up, as I mentioned, those couple of times, either for no reason, just spontaneous, we'd have to go to the bathroom, but he would easily return to sleep with the Ambien 5 milligrams. And then he'd wake about 6:15 to 6:30 or later on the weekend. So he was averaging 7 to 8 hours, feeling good, most of the time feeling rested during the day, able to function at a high level. He'd not had a sleep study before, and generally he denied symptoms concerning for other sleep disorders, including sleep-related breathing disorders, RLS, parasomnias. He denied any side effects from Ambien, either hangover effects. He wasn't having anterograde amnesia, so he was tolerating the Ambien 5 milligrams pretty well. terms of his medical history, he had GERD, asthma, allergic rhinitis, and he had a bout of Bell's palsy. You can see his medications there. He was on a nasal spray, Nexium, he had an inhaler for his asthma. He was on loratadine and then the Zolpidem 5 milligrams. Mental health history, again, not very interesting. Denied history of symptoms concerning for mood disorders, anxiety, substance use disorders. He did have a kind of a baseline higher level of anxieties that I've already sort of articulated. Denied trauma, he'd never had treatment for any mental health disorder. And then finally, in terms of other clinical measures, he scored within the normal range on the audit. That's the alcohol use disorder inventory, the Epworth, the GAD-7, the PHQ-9. He scored in the subthreshold or the mild range on the insomnia severity index. So when I asked him about his treatment goals, what he wanted to get out of treatment, he had two goals. The first was to first get decent sleep quality and not worry about it. And his second goal was, I asked him about medications. What did you want to do with the medications in particular? He said, I wasn't really sure what to do about the medications. So that's the first visit. And I'll just pause here and ask the fellows, what do you think is a primary differential diagnosis here for this patient?
Sleep apnea.
Good, yeah. Sleep apnea based on?
Fragmented sleep, waking up, going to the bathroom overnight, and like the unrefreshing sleep.
Oh, okay. Could be. Yeah, sleep apnea. Any other guesses?
Like a movement disorder with sleep, like REM behavior disorder, like preventing him from, getting quality sleep overnight.
Okay, could be. Yeah. Any others?
I mean, insomnia, right?
Yep.
Specifically looking at like, it could also be like mental. You said he has a baseline level of anxiety. So maybe a psychosocial component to his insomnia.
Can you diagnose insomnia in somebody? He doesn't have very many symptoms, right? He sleeps pretty well, as you saw. Can you get a diagnosis of insomnia in that case?
Well, you said he said he sleeps well when he has the Ambien, right? After he got back from Europe.
Yep.
So I think so, but correct me if I'm wrong. I thought, like, I guess, like, if he's not sleeping without the Ambien and it's been going on for 3 months, if he came back in March, then I guess you could make the diagnosis, but.
Yeah. No, I did that. I want to pause and highlight that. Yes, you can make the diagnosis in this case. He's not symptomatic on the Ambien, but you can assign regular users of hypnotic medications who sleep well the diagnosis of chronic insomnia disorder. The assumption being that if they don't use the medication or you have evidence they don't use the medication, that they have insomnia symptoms present. So my main differential here was chronic insomnia disorder. How about a treatment plan? What would you recommend as a treatment plan for this guy?
Can I add 2 cents for a second?
Sure.
Because I see this sometimes in notes, and it's not just here, it's everywhere. Our language is so problematic sometimes in sleep. Like, obstructive sleep apnea can be an event or it can be a diagnosis. In insomnia, there's also confusion between symptoms and diagnosis. So to talk about the disorder, it should be chronic insomnia disorder. And if we just say he has insomnia, what you're saying to another sleep specialist is that he has symptoms of insomnia. So, you better be careful on my advice is to, distinguish those. And the second thing is RBD. It doesn't usually affect your sleep. How many times you see a patient with RBD who tells you they have a big complaint of insomnia? Not often. They usually say they sleep great. It's just my wife says I'm punching her. It's something like that, or they punching the wall or whatever it is. So keep that in mind too.
Yeah. Thanks, Ron, for that input. The main point I wanted to make was that you can assign chronic insomnia disorder. You're right. We should use the diagnostic term in the presence of somebody who's using hypnotics, but asymptomatic. That's a reasonable diagnosis. So how about his treatment plan for this guy based on his goals? So he wants to sleep fine, not worry about it. not too sure about his medication. Any thoughts on what the plan would be?
I mean, I feel like you got to start with the things that are more like the behavioral modifications. When you were going over his sleep schedule and sleep hygiene, there does seem to be like areas of intervention when it comes to sleep hygiene, watching TV in bed, being on your phone in bed, reading in bed, alcoholic drinks 3 to 4 nights a week. Alcohol has been shown to affect sleep. You drink coffee, cappuccinos, early afternoons. Half-life of caffeine can be long in certain people, and over 6 hours sometimes, you know, and so that could also be affecting his sleep. My
Good,
thought
Debbie, so we've got
process,
some target. Yep.
yeah, my thought process has always been it has to be like a multimodal approach. You got to approach it from multiple angles. There's not going to be one single thing you do that's going to immediately fix this guy's insomnia, and like his dependency is which seems to be on Ambien.
Did you do anything with the medication to start? Would you give him any recommendations around the medication?
I probably like once he's done the behavioral modifications, then would probably try to get him to wean it. Was he taking 10 milligrams or
5, taking 5.
he was taking 5? Okay. Well, you know, I will say as someone who has suffered from insomnia in the past and has been on that medication, I did split it in half, and I would take sometimes like 2.5 milligrams at times, and it would get the job done. So I don't know if that's going to be something I would recommend as a professional, but from a personal perspective, at the end of the day, you're getting that effect of the drug, right? And maybe there's a psychological dependence on it. Whether or not you get that 2.5 milligrams is going to actually improve your sleep onset latency or not, who knows? I don't know if they've ever studied that doses that low, but yeah, that would be what I would say. Is probably just start by like maybe not taking it as frequently, and then if possible coming down on the dose. But I defer to the more experienced people here on how to manage this difficult case.
Yeah, no, I don't think there's a right way. I mean, there's not an absolute protocol. So this is what I decided to do. So it's sort of along the lines, Debbie, you're suggesting is given his relative ambivalence with respect to the medication, I said, let's start with CBT, and let's essentially keep the Ambien where it's at. So take it 5 milligrams nightly. And then let's have you keep a sleep diary. Let's see what's going on. And then we'll continue to have a discussion related to medications and your longer term desires related to that. And I recommend no sleep study initially, although possibly has occult OSA, but didn't feel like we needed to start there. Okay, so he comes back for his
Todd, it
first
looks
return.
like Brad had a question about.
Oh, I'm sorry, I can't see the
versus
chat very good.
Sleep diary.
Brad, can you unmute and say what your question is?
Sorry. I just like part of my plan, I think like would be to see what his like sleep. I mean, I prefer actigraphy, but or like if possible, but or getting like a sleep diary to see like is he, you know, how much is he really sleeping and what that looks like.
Yeah, so we chose a sleep diary, a little simpler. Generally, at least to start, if we have confidence that people can assess their sleep reasonably, okay, then we'll just start with a diary, not necessarily use actigraphy, but you could use actigraphy if you wanted some additional information. So it comes back after a couple of weeks, 3 weeks later, in fact. You can see his diary summary on the left here. This is a summary of CBTI Coach. And he's still on his Ambien 5 milligrams. Since I saw him, he traveled, and remember he had trouble sleeping when he traveled to New York, and he actually took Ambien 10 on those nights. But he struggled a little bit more, and he was getting more anxious about his sleep. So he would sleep later in the morning to try to make up for that. And he'd increased his dose to 10, at least on that trip. He thought about what he wanted to do with medications, and he was clearly ambivalent about his goals around medication. So he said, on the one hand, it helps me sleep and I feel less anxious about my sleep, but I'm concerned about developing tolerance over time. Remember, he'd only really been taking it for 2 weeks straight at this point, and historically he would take it for a bit and then stop. And then long-term health consequences on using Ambien. And when he sleeps poorly, any nights he doesn't have a great night of sleep with the medication, his anxiety about his development of tolerance increased. So there you can see his baseline sleep diary. And I've tried to highlight the sort of most relevant parameters. So you can see sleep latency. It may be hard to see those numbers. So I can tell you that they're right around 30 minutes. His wake after sleep onset average is about 5 minutes. across those 3 weeks. This is weekly averages across 7 days, obviously per week. Total sleep time, he's averaging between 7.25 to 7.5, and his sleep efficiency ranged from 88 to 90. So this was an initial session, introduction. Here's what CBT is all about. And mostly covered just sleep hygiene in this first one. Any thoughts on his sleep diary?
Looks pretty good.
Yeah, right. That's a good summary, Brad. Looks pretty good. Looks pretty normal, right? It's within normal limits on all these parameters. So again, we don't have, sort of consistent with this report, we don't have a lot of insomnia symptoms. So any ideas on what to do, especially about medication here? So this is mostly just introductory, so we hadn't started anything yet. But any thoughts on what we should do, if anything, with his medication at this point?
I don't know. I think I would kind of go with Abby's approach and we try splitting it and seeing how that goes. Maybe for a few nights a week, at least getting some assessment if it's working for him, if that's his plan to try to come down eventually.
So you might move forward with changing the medication dosing at this point? And
Yeah,
in
at least
some
a
way try-
trial. Yeah, at least a trial, like, and to be able to report back on how things went. I think give you some more data if that's a possibility in the future, and maybe give you a better idea about how quickly, slowly you need to do it. If that's the
Also, he
Well,
seems to have significant anxiety concerning his sleep, and it seems to be a recurring factor. And so, I mean, I don't know how we would address that aspect of it. You know, the more you think about your sleep and worry about your sleep, it can contribute to the insomnia and the dependency he has on the medication. So, I don't know, maybe also approaching it from that angle might be helpful.
So first session, I stood pat. I didn't do anything. I didn't make any changes. I just was, again, recognizing his ambivalence around his sleep, and he hadn't really moved far. So I said, let's keep the Ambien where it is. We'll continue to, we hadn't really done any behavioral strategies yet or anything. So we left the Ambien where it was, just had him start some sleep hygiene things and then continue with his sleep diary. So here he is, a couple of weeks later, his next return visit. And he says, I'm doing, quote, pretty good. Most nights, very few issues. He had actually gone ahead, even though our plan was to do Ambien 5 milligrams, he'd gone ahead on one night. He took no Ambien. On another, he took 2.5 milligrams. But he struggled to sleep on those nights, so he ended up taking the full 5 milligrams on those nights. So I don't see that as a victory. That could almost be a setback in some ways, right? But you can also see he's sort of moving forward in some ways. He's expressing in his behavior his commitment to make a change. So he's experimenting with it on his own. And the night before I saw him, he ended up taking 10 milligrams. So now he's starting to escalate a little bit. But he did say overall he felt less anxious about his sleep. And I'd given him the behavioral chapters from Quiet Your Mind and Get Some Sleep. And he'd actually started to implement those things on his own. So he was waiting until he got tired to go to bed. So he's staying up a little bit later, generally speaking, and he would get out of bed if he wasn't able to sleep. So he's engaging in stimulus control strategies. So he'd already started those on his own, showing some commitment to the behavioral strategies. He did have an upcoming trip to Paris, though, and he was really nervous about his sleep and how he would do on the trip. So again, you can see his sleep diary. We got 3 more additional weeks of sleep diary. Any comments on the diary? Again, I've got the main parameters highlighted. Just eyeball them. You can see it kind of had one rough week here. But otherwise,
Looks pretty good.
right. Still sleeping pretty well, right? He's on 5, sleeps pretty good. Now we got 6 weeks of data or 5 weeks of data, 6 weeks of data, and he's sleeping well. So what do you think we should go ahead?
I'll say, what's
Sleep.
the biological sleep need? What is that referencing?
I don't know how they calculate that.
Oh,
To be
okay.
honest, I ignore it. That's what I do. I ignore it. 'Cause I'm not sure how they calculate it. But it's a good question, Brad. So based on his diary, and this was a behavioral session, so we did talk about sleep restriction and stimulus control strategies. Any thoughts? Where should we set his bedtime or his sleep window at? His sleep schedule? How long should it be? His time in bed?
7
Diaz, any
hours.
thoughts? 7's not a bad choice. Yeah. What are you basing that on, Brett?
His total sleep time, like maybe a little bit more, 7 hours and 30 minutes.
Yeah, good. So if you eyeball his total sleep time, it's somewhere between 7 and 7.5 hours. So you could set it 7 to 7.5 hours would be kind of a reasonable starting point for his time in bed. And what about his medication? Did you make any changes at this point to his medicines now? Started the behavioral strategies, sleeping pretty well, not very many symptoms.
Probably not because of his trip to Paris.
Okay, right. Yep. And so I did not. Again, I left it at 5. Continue to just have discussions around this. I'm not sure why I set a 6.5 hour window on retrospect. I don't know if I wrote that down incorrectly or I was feeling super aggressive on this particular day. I think a 7 hour would have been perfectly appropriate, but I said it's at 6.5 hours and then stimulus control. That was our plan.
Todd, I have
So
an
then I saw-
observation.
Yeah.
It's interesting to me that he says he feels like his anxiety related to sleep is better, but then it seems to me like this, within one day, double the dose, and his behavior maybe seems to belie that statement. I was just wondering if you kind of addressed that head on or just kind of took the discussion at face value and proceeded.
I don't remember like explicitly, but it is a good strategy, generally speaking, to if you hear what somebody's saying and you see something different in their behavior, that you elicit that, you point that out to them and just try to see how they fit it together or how they might clarify it. I don't remember if I did it in this case. I was just going off my return visit notes and I don't remember, but as you'll see, I do remember that he did have a shift in his thinking around his sleep and use of medications along the way. And I think that was instrumental for him at one point to make some changes. So when I saw him a couple of weeks later, he said, now sleep kind of depends on the day. In doing the behavioral strategies, he'd find that if he was sleepy enough when he went to bed, he was good. He could consistently fall asleep. But on nights when he did feel tired, it made him real anxious. He'd get super anxious, especially if he'd taken the medication. And that might lead to more difficulty falling asleep. He still had ambivalence around his medications. And he said there'd be 2 conditions under which I decide that I really want to stop them. Number one, if somebody could tell me they're definitely harmful to me if I continue to use them. And number 2, if I started to consistently escalate the dose beyond 5 milligrams. Well, he'd already started to escalate the dose. You saw a few times when he was going up to 10 milligrams. That wasn't typical for him. We had a behavioral plan in place, but he actually showed some sort of mixed adherence with the behavioral plan, which is, I think you can get stuck with patients who are taking medications because they have that sort of out, if you like. And so they don't have to necessarily commit fully to the behavioral plan. And I feel like we got stuck in neutral, as you'll see a little bit with this case. If you remember, his bedtime was 11:30, wake time 6. He went to bed closer to 11. He was pretty good with the wake time. He was pretty adherent with stimulus control strategies from the weeks prior, but in this case, he said he didn't have any occasions when he needed to implement it. You could see his sleep diary. Any comments on the diary here? Now we've got a full 8 weeks of diary. Pretty consistent, right? He's sleeping other than that 1 week. I don't recall offhand if anything in particular contributed to that. But in general, he's still sleeping pretty well, right? So he doesn't have a lot of symptoms. As I say, feel like we're kind of in neutral here. He's ambivalent. I'm not having a lot of headway in terms of moving in one way or the other on medications. He's behaviorally showing maybe he wants to make some changes. He's doing things kind of on his own. So as I say, I feel like I'm stuck in neutral, and I continue to be stuck in neutral. As I just said, keep your medication where it's at. I set his schedule to 11:30 to 7, and I noticed that he was spending more like 8 hours time in bed. As you can see from the last couple of weeks, it was close to 8 hours. So I recommended he reduce that down to 7.5, and continue with stimulus control therapy, which he was generally adherent with. We did talk about cognitive strategies. Here's where we introduced that. And in addition to having him complete a scale, the dysfunctional beliefs and attitudes about sleep scale, I sent him home with an automatic thought record to actually record the thoughts that he was having in moments when he was having difficulty falling asleep. So now I didn't see him for another 6-ish weeks or so. And he'd gone to Paris in the meantime. He actually went to the Olympics in July last year. And now he'd returned from Paris and he was sleeping well at home on Ambien 5 milligrams, back to his 5 milligrams. But he noticed when he was traveling, he felt really anxious now when he was traveling and felt even more unsettled than he had historically, where he'd felt anxious about sleep, but now it was a more generalized anxiety when he was traveling in particular. And so as a result, he began to see a psychiatrist. As I mentioned, he had no history of mental health treatment, to talk about his anxiety further. And he's, again, continued to express ambivalence about reducing Ambien, but he did feel like he needed one of the ways that he could manage anxiety when he was traveling was to have kind of a more consistent travel sleep plan. And so we, as you'll see, we start to talk about that. And again, he continued to have mixed adherence with the behavioral strategies, generally speaking. He was not totally non-adherent, but not all that adherent, other than with stimulus control therapy, but not with the sleep scheduling strategies. So just in the interest of time, I'll show you what our plan was here. Again, I told him keep the medications where it's at. Now I really feel like we're in neutral. We talked about plans for traveling, which I actually suggested that he come up with a plan that he could implement when he traveled. And everything else stayed stable. I introduced strategies for reducing arousal. Abby mentioned that. So mindfulness exercises, for example, and asked him to sample those for discussion next time. Second last return visit. Now he'd gone to Scotland since I'd seen him. And there he'd escalated his dose a little bit. He oscillated between 5 and 7.5 milligrams while he was there. But when he returned, he had actually managed to reduce Ambien on his own to 2.5 milligrams. And he tried that the week prior to going to Scotland. Again, out of the blue, wasn't necessarily part of the plan. But he decided he wanted to, on his own, try to reduce it. He did. And when he came back from Scotland, he got him back down to 2.5 milligrams. And he was actually sleeping pretty well. So now he was engaged and interested in stopping Ambien when he was at home, where he slept well. He could do 2.5, sleep consistently well there. And he said the main changes in his cognitions that led him to this notion that he wanted to stop, at least at home, was he realized his functioning wasn't as bad as he feared after bad nights. If you remember, initially he said he was basically essentially useless when he didn't sleep very well. And really only 2 or 3 nights a year, his functioning was significantly affected by bad sleep. So we, again, looked at a home versus a travel plan in terms of having different strategies to try to manage his anxiety and be explicit about what he was going to do in each situation. So at home, he was going to continue with this 2.5 and start to introduce drug-free days, because now he felt like he wanted to try that at home. Travel, he was going to implement key behavioral elements for him and just use 2.5 milligrams of Ambien. And again, just to move forward, but this is a pivotal moment. And so he started to try to introduce medicine-free nights while at home. Otherwise, and he had a chance to implement the travel plan the following week. He was traveling to Vegas, and we were still having him track his negative sleep-related thoughts on the automatic thought record, which were pivotal, I think, for helping him to make these gains in treatment. Final session. He says, going really well. He stopped Ambien entirely for 10 days, stopped it entirely. And he did it by stopping Ambien, taking CBN gummies for 4 or 5 days, and then melatonin gummies for a few days, then nothing. And he'd been off now for a few days, not terribly long, but he'd been off for a few days. Still seeing the psychiatrist. Recommend that he take tryptophan for both his mood and his sleep. He was kind of considering it, but hadn't committed to it. He had felt like the most effective CBT strategies for him were not spending too much time in bed. And he'd really tried to get down to 7.5 hours, felt like that was the right number of hours for him, regularizing his sleep schedules, not napping, and then getting out of bed when he wasn't able to sleep. So victory. Our plan was we at least achieved part of his goal was to make changes maybe to his medication. So he had achieved that at least in the home environment. Continue no Ambien at home. He had a solid plan now when he traveled about what to do. He had the wind down. He'd use a lower dose of Ambien, stay on his at-home sleep schedule, stimulus control, and then we talked about sleep maintenance and relapse prevention. So I just discharged him, sent him on his way. All good. Victory. I get an email 6 weeks later. Hey, Dr. Ardit, I hope you're doing well. As you know, I've been seeing a psychiatrist. He wants me to try Remeron. he thinks that I'll sleep more soundly on Remeron. I've been sleeping pretty well, but I still wake up, go to the bathroom. And so I want to know what your thoughts are on Remeron. So I'd like to try that in part for my sleep. And by the way, I am taking that tryptophan for sleep. So, we made those gains, and then at the end, he ended up returning to medication. So I think this is a really reasonable example of patients that we see in clinic who are really ambivalent about making these changes. And it really elicited some relevant questions for me, which we won't have time to go through, right? We're almost at time, I'm thinking. I don't have a clock, but yeah, 2:00. So let me just ask for feedback on what do you think should be our message to patients regarding their chronic use of hypnotics? That first visit, what should we be telling patients, do you think?
Well, I think as you alluded to, I think the shared decision-making there is really important in understanding what their goals are. I think there might be some self-selection of people who come to our clinics, maybe looking for a change in their course of therapy. But I usually try to engage in that type of, gauging of their intent, and then also some shared decision-making, because I feel like if we're too heavy-handed, we lose them right from the start.
Any other perspectives on that?
I think
Based on experience?
it's like a lot of like depending on their age. Sorry, I don't know if you can see me, but like
Yep,
if they're like
see.
younger patients, right? Like I would be more inclined to try and figure out, if we can get them off the medication, and then also like if they're older though, like which hypnotic are they on, and like that depends on like how aggressive I would want to get them off that medicine.
Even if they said, "Hey, I'm happy to be on this medicine, I don't want to get off it."
Yeah, I mean, if they're like, old, elderly and risk of falling or like dementia and they're on Ambien, I definitely would be more aggressive about getting them off that.
How do others approach this particular issue?
I just think it's important to set expectations, like kind of when you feel out at the beginning, like kind of what their plan is and their outlook and their intent, and then you kind of give yours, and maybe especially with a lot of time trying to keep people off of these medications long term, kind of like give an explanation. This might not be like usually in a long term plan they would like to do, but kind of work towards getting off and setting the expectation that it might take some time. And that, I feel like that helps with kind of the longevity of the plan. It seemed to have worked in this case as well.
For bed, anyway. Anybody else? Rod? Anybody else who's still left? All right, well, I don't think we have time to get to other discussion issues, so I guess I'll have to stop there, but I want to thank you for your insights, and maybe I can come back and present the rest of it another time.
Thanks, Todd and Montito. These were fantastic cases and great discussion. So, thank you.
Thank you.